This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Thomas Smith, Harry J. Duffey Family Professor of Palliative Medicine and Oncology at Johns Hopkins Medicine.
Thank you.
Patients that are lucky enough to be in a center where there is a palliative program can have easy access.
Right.
But what about the majority of cancer patients that are seen in the community setting and they have a medical oncologist, but there really isn't a system or referral in place to get them to a palliative care specialist?
There are two things that might be helpful. One is we're trying to get every single medical oncologist in the country to estimate how long we think people have. And when you think somebody's got 3 months, 6 months, 12 months to live, have them interview with the hospice team. I call it a hospice information visit. Oncologists will say, well, there's no way we can estimate that, 6 months to live. It's baloney. With most diseases, you have a set of triggers that it could be 8 months, it could be 4 months, but the range is, you wouldn't be surprised if this person were to pass away within the next 6 months. So you send hospice out, so they get to interview with a social worker and a nurse, find out what hospice is. That often opens up this tremendous dialogue about, oh, so you'll be the people taking care of me when I get to that point. That's really comforting to know. There's one program that's doing this really well. One of the big practice plans in the United States has appointed somebody in the office. It doesn't have to be the physician to address these issues as soon as a person is identified with a life-limiting illness. So rather than doing this on the last 3 visits, it is best practice for these groups. You do it in the first 3 visits. And it works really well.
How do we help doctors feel okay about integrating palliative care into the clinical setting?
I think the only real way for doctors to learn things is to have a good experience. So you send somebody to a cardiologist, and the cardiologist picks up the phone after seeing the patient, and she tells you, oh, yes, you did exactly the right thing in treating their early congestive heart failure, and I've made a few tweaks to the medicines, but I think things will be fine. You can go, that made my life easier and better, and it will make my patient's life better and her family better too. So if oncologists like me have a good experience with palliative care, then that's the only thing that's really going to get us to call. What we're trying to do is drive this in a couple of ways. One is to get patients to ask for it.
Yes.
So patients can go to getpalliativecare.org, so getpalliativecare.org, and find out who in their area actually does palliative care. Because you would be surprised how many places are popping up that do palliative care. The National Hospice, NHPCO, www.nhpco for the National Hospice and Palliative Care Organization.org, that has a lot of places in your locale too. Because a lot of hospices are recognizing that oncologists like me refer people late. At our center and most centers, 20% of people go into hospice with less than a week to live. When this didn't suddenly just come up and bite you, it's been something that's been fairly predictable for quite a long time. One of the things that hospices do is these hospice information visits, and some of them will even allow the person to be in the care of the hospice and palliative care team while they're still getting chemotherapy. And a lot of insurers actually encourage this. I mean, Aetna's compassionate care program identified people from the computer records. So they would see that, oh, Dr. Smith is treating Mrs. Brown for breast cancer and brain metastases. And they, of course, had no idea what I'd told Mrs. Brown about her illness, but they would call up and say, we're from Aetna's Compassionate Care Program. You actually qualify for extra benefits. You'll have a nurse case manager to help you. We can help you with symptoms. There's a 24-hour line you can call if you're short of breath, or if you're depressed, or if you're anxious. We have palliative care and hospice providers in your area, and we'd like to set up an appointment. And one of the things we ought to think about when people are sick is to think about advanced directives or living well. And they found that people live just as long. They didn't have any way of measuring symptoms, but it really changed the experience in the last 6 weeks of life. So the number of hospitalizations went down by 7-fold, not 7%, but dropped by 7-fold, from 15 days in the hospital per member down to 2. And the number of ICU admissions dropped by almost 10-fold, from 10 days in the ICU for a seriously ill cancer patient, which is not where most cancer patients want to be, to 1. And it was as simple as having a service available to help you with your symptoms that you'd establish some trust with. So if you couldn't necessarily get through to your oncologist or find somebody at 2 o'clock in the morning, you could call this number and they'd say, all right, we can walk you through that. And we can even have a nurse come out and visit you and make it so we'll fix the pain and the shortness of breath, and we'll lead you through what's happening so that person doesn't end up in the emergency room at 3:30 on a Thursday morning, doesn't get admitted to the ICU because nobody's had any advanced directive discussions, and that's not where they want to be.
First, I want to say thank you.
All
I want to say thank you first.
You're welcome.
Dr. Thomas Smith, the Harry J. Duffey Family Professor of Palliative and Oncology Medicine at Johns Hopkins Medicine.
Thank you.
Thank you, Dr. Smith.